Hi. Our panel is called Cross-Cultural Perspectives on Technology Uses in the Beginning of Life. And the first speaker will be Dr. Tsipy Ivry, who is a medical anthropologist studying the cultural politics of reproductive medicine and reproductive technologies among various communities in Japan and Israel. Tsipy's book, Embodying Culture, Pregnancy in Japan and Israel, summarizes her comparative ethnographic research on prenatal diagnosis in Japan and Israel at the beginning of the second millennia. Since 2006, she has studied the cultural politics of assisted reproduction among deeply religious Jewish communities in Israel, focusing on rabbinically mediated fertility treatments and post-diagnostic abortions. Most recently, Tsipy is studying genomic testing, pregnancy, and parenting following the March 2011 disasters in northeastern Japan. Her talk today presents her preliminary findings. I'm sure it will be very interesting.
Thank you so much, Yael. Thanks, everybody, for inviting me.
I can barely hear you.
Yes, we need the microphone.
I need the mic. Okay. Can you hear me now? Okay. Can you hear me now?
No, yes.
Okay. So, this is the first time that I'm trying to wrap up my findings from 2 years of field work.
They still can't hear you? I'm not sure. You have to really...
Okay. Okay. So, this is the title that I gave, but actually I'm really concerned about paradigm shifts and about the question of whether new technologies and disasters actually can bring paradigm shifts. And I'm trying to use ethics as a perspective to think about these questions. The idea that reproductive technologies transform modern societies around the globe has been reiterated in anthropological and sociological studies of human reproduction over the last 4 decades at least. Technologies diagnosing fetal anomalies in utero were claimed by Katz Rothman to have made American women experience their pregnancies as tentative. Rainer Rapp famously claimed that amniocentesis pushes women to moral pioneering when they face the decision of whether to terminate the pregnancy of a fetus diagnosed with an anomaly. Obstetric ultrasound, on the other hand, a technology whose diagnostic implications can be obscured within specific sociocultural circumstances, was seen to have transformed fetuses into fully fledged patients in Euro-American settings. However, these persistent assertions about the transformative powers of prenatal diagnosis have not been grounded in any previous longitudinal documentation of pregnancies in concrete socio-cultural settings. Moreover, such social transformations have rarely been documented as they are happening on the ground. This is precisely what I'm looking to contribute, a longitudinal perspective from a 15-year-long ethnographic exploration of pregnancy and prenatal care in Japan, one that looks at experiences of pregnancy and their medical management within an interplay of prenatal diagnostic technologies, local politics of reproduction, and the social consequences of a triple disaster. Japan, an Asian hyper-technological modern democracy, offers meaningful example of a social setting in which pregnancy is medicalized and technologized, but medicalization operates along particularly local trajectories of institutionalization, bureaucratization, and sense-making, employing local styles of authority. As time allows for only a very limited presentation of this interplay using my previous and current research, my analysis today will focus on the introduction in Japan in 2013 of a new genomic non-invasive test analyzing fetal DNA in maternal blood known as NIPT, non-invasive prenatal testing. A white paper issued in 1999 by JSOG, the Sanfujin Kaikai, the Japanese Association of Obstetricians and Gynecologists, actually exempted doctors from informing pregnant women of the existence of another test, of AFT, alpha-fetoprotein analysis of maternal blood, used as screening test in the US, Europe, and Israel. That extension in mind, the new guidelines for NIPT seem to signify a turning point in reproductive governance. Based on my previous comparative work on pregnancy and prenatal care in Japan and Israel, and preliminary findings from my current ongoing research since July 2014, examining pregnancy and genomic technologies in the aftermath of the March 11 disasters, I ask whether the medical and lay cultures of pregnancy and prenatal care in Japan are undergoing a paradigm shift. Let me explain this through a brief review of my previous comparative study. A central question that oriented that previous study was, what is it that makes prenatal diagnosis and its underlying scientific body of knowledge so widely acceptable in one technological democracy, Israel, and so contested in the other, Japan, an Asian democratic society which is equally technologized and medicalized? My findings illuminated two different cultures of pregnancy and biotechnology underpinning local trajectories of medicalization. To give a sense of this difference, let me explain how medical bureaucracies conceptualize pregnancy. Conceptualized pregnancy, conceptualized pregnancy. Japanese women's pregnancies are monitored from about the 10th week in a mother-child health book. It's a medical record, it's on the right side, it's a medical record that documents maternal health from the stages before inception through prenatal checkups with no mention of prenatal diagnosis, then birth until the baby's 5th year. By contrast, Israeli women's pregnancies are monitored in a pregnancy monitoring card, a record of prenatal diagnostic tests. Only on her discharge from the hospital after a successful birth does an Israeli mother receive a separate vaccination card for the newborn baby. The Japanese bureaucracy defines the pregnant woman as a mother who for now happens to have her baby inside her, while the Israeli bureaucracy separates pregnancy from motherhood. Each definition suggests specific ethical stances toward pregnancy, and women were conversing and negotiating with this ethics. I found that in Israel, women, their partners, and medical care providers tended to see pregnancy as highly tentative. Fetal subjectivity tends to be suspended, and maternal bonding approached carefully. In Japan, on the other hand, pregnancy was widely conceptualized as an early stage of parenting. Maternal-fetal bonding was encouraged, and women, through culturally established daily practices of bonding, and I can tell you a lot about this, but I don't have time, related to their unborn babies as fully fledged human beings with subjectivity. Unlike Israeli doctors who readily offered a battery of prenatal diagnostic tests, which were backed up with a very liberal abortions law, Japanese OBGYNs were reluctant to inform patients about prenatal diagnostic options. They were also reluctant to discuss chromosomal reproductive risks, even with older women. Underlying their authoritative communication style was their perception, this is what they were explaining to me when I was sitting in their clinics, that information about chromosomal risk is a risk factor in and of itself that endangers the pregnant mother's sense of well-being. They saw it as their responsibility to minimize pregnant women's worries and secure their mental well-being. The maternal body protection law allows terminations until 20 weeks and 6 days of gestation. Diagnosis of fetal anomaly, however, is not listed among the acceptable reasons for termination, and thus failing to diagnose does not expose doctors to malpractice lawsuits. Prenatal diagnostic technologies were, however, definitely practiced, and post-diagnostic terminations were certainly occurring secretly in the backstage of prenatal care. Rather than chromosomal and genetic factors, Japanese OBGYNs emphasized the various ways in which mothers can make the health of their babies through monitoring their own nutrition, weight gain patterns, physical activity, stress levels, exposure to noise and air pollution, so on and so forth. They saw the maternal body as an ecosystem, encapsulating the unborn child, and made the pregnant mother responsible for controlling her own somatic and mental environments. And when I'm talking about somatic and mental environments, I'm talking about emic ideas that are also bureaucratical, shinkyo and kankyo, which are monitored in this mother-child handbook. I called the Japanese regime of prenatal care environmentalism and contrasted it with Israeli geneticism. I'm sorry, I forgot about all this. And then on March 11, 2011, an earthquake of unprecedented magnitude and subsequent tsunami that wiped out whole communities along the northeastern coast and caused multiple meltdowns and explosions at the Fukushima Daiichi nuclear power plant put pregnant lactating mothers and parents more broadly in an unbearable position. The environment they were charged with monitoring for the health of their unborn children and babies collapsed, and health experts provided contradictory assessments of risk. On March 15, Japanese Society, the JSOG, the Japanese Society of Obstetrics and Gynecology, warned pregnant women and nursing mothers to go as far from Fukushima as they could, or to undergo potassium iodine treatment in case of exposure. Worsening radioactive fallout caused low-dose contamination of tap water in Tokyo, and mothers were warned not to use it to feed their babies. Agricultural and sea products were soon to be announced at risk. But on April 1st, with escalating public anxieties, the Japanese Ministry of Health employed their familiar style, it was very familiar to me from the clinic, of worry prevention governance, and distributed 3 million pamphlets to pregnant mothers and to pregnant women and mothers, emphasizing that food, water, breast milk outside the exclusion zone, which was redefined several times, were all safe and within the government's provisional standards. And noting that anxiety, and this is what's written there actually, anxiety over radiation endangered the health of fetuses and children more than the radiation itself. This is from the site of Japan Ministry of Health. Genetic counselors and clinicians with expertise in genetics suddenly became visible in the aftermath of the triple disaster. The radiation counseling they provided for people who suffered from anxiety, this is not a very good translation, and if I'll have time, I'll explain it to you. It's not anxiety, it's huang. And it's another concept. It's all about fearing the unknown, but it's not about anxiety. It's not even about panic. Anyway, they gave radiation counseling to people who suffered from huang about the health effects of radiation exposure, and they were bitterly criticized by environmental activists as a way of hiding information from the public. But I was this style of huang prevention governance was so familiar to me, and I suggest that rather than hiding information, these authority figures were practicing a particular style of governance that actually they were expected to provide this kind of governance by the people that I spoke to, that aims at minimizing the health risks of risk information itself. The disasters, however, powerfully illuminated that in an age of global risk communication, this style of governance becomes a double-edged sword. Returning to pregnant mothers themselves, they were documented as feeling guilty toward their unborn babies for not being able to provide a proper environment for them. Faced with contradictory risk assessments from government officials, OBGYNs, pediatricians, epidemiologists, public health experts, and Japanese and foreign international health organizations, mothers increasingly voiced their distrust, demanding clear information about the effects of low-dose radioactivity. Many even bought their own Geiger counters. The idea that reproduction can indeed go awry, that children could be born with anomaly, surfaced with unprecedented thrust. It was silenced after World War II, unprecedented thrust in public media, partly due to the demonstrations of Fukushima mothers, widely covered by the media. This left me wondering how this would impact the governance of reproductive risk. And then, I'm sorry. Just can't handle both. In March 2013, the JSOG issued guidelines for NIPT The test was issued to indicate 3 trisomies, 13, 18, and 21. Eligibility is limited now to women over 35, women who have given birth to children with anomalies, or women who have had indications of anomalies from other non-invasive tests. NIPT is not covered by health insurance and costs 200,000 yen, $2,000. It was carefully introduced as a clinical trial, and your organization, a consortium of medical doctors with expertise in genetics and genetic counselors, was established to monitor NIPT uptake and results. Sequenom, the US company that developed the test, claims a 99.1% detection rate for trisomy 21. Medical practitioners cited this high credibility as one reason for introducing the test despite the JSOG's reservations. Women who test positive in the NIPT still have to undergo an invasive test, amniocentesis, if they want definitive results. Couples who are eligible and interested in doing the NIPT must undergo genetic counseling before the test to confirm their decision, and after the test to receive the results and discuss the possibility of further testing. Additional counseling is required if the couple decide to undergo amniocentesis. Soon after the issuing of guidelines, the Japanese media exploded with ethical condemnations of the selective aspects of the new technology. But demand for NIPT is on the rise ever since. Interestingly, articles about the procedure used the term fetus. If anybody can read Japanese, then that's fetus. That was very. This is rare in Japanese newspapers and media to call the baby the unborn baby a fetus. So. The introduction of NIPT raises various questions for pregnant women, their families, and care providers. Does NIPT suggest a new governance of chromosomal and genetic reproductive risk, and a new visibility for genetics as an explanatory model for health and illness? Will care providers now discuss chromosomal and genetic reproductive risk more straightforwardly with pregnant women? And how will NIPT impact women's experiences of pregnancy as well as the moralities of pregnancy, and particularly maternal bonding? Will Japanese pregnancies now become tentative? While I don't as yet have clear-cut answers to these questions, I will show you several snapshots from 4 different field trips since 2015, in which I conducted interviews with pregnant women about their experiences with NIPT, with OBGYNs and genetic counselors, and from recent observations in a children's hospital in Sendai. My first discovery was that the previously unfamiliar profession of genetic counseling is gaining visibility in contemporary Japan. While in other hyper-technological countries, genetic counseling has been an established profession for at least 2 decades, in Japan the Ministry of Health licensing system for genetic counselors only commenced after the NIPT guidelines were issued, and the scarcity of certified counselors became apparent. It's 100 counselors in Israel and about 180 in Japan. But since the introduction of NIPT, demand is rising in Japan for these professionals. Genetic counselors, the majority of whom are women and often midwives or nurses, complain about the low standing of their profession and the low scientific literacy of the clients. Some claim the Japanese are allergic to genetics. In a country whose A-bomb survivors' body tissues and longitudinal health statistics were used to advance American genetic science, and where the first automated DNA sequencing device was developed as early as 1981, public discussions of the genetic aspects of health have long been silenced partly due to their association with World War II eugenic ideologies and practices. Mendelian heredity in plants has long been part of the school curriculum, but attempts to link it to human genetics started only in 2015, when the Association of Science Education and the Japan Genetic Counseling Society set out to improve genetic literacy following the introduction of NIPT. Genetic counselors in Japan use few metaphors when trying to make, that's the second snapshot, they use very few metaphors when trying to make genetic knowledge accessible to their clients. They feel uneasy speaking about the genome as the blueprint of life. When they finally use metaphors, they draw on more familiar idioms to explain that the genome is like a recipe that one uses for cooking. The recipe is the same, but each time due to slightly different ingredients and slightly different pots and pans and slightly different dish, a slightly different dish is cooked. Beyond scientific literacy, and it's really interesting to see that even when they attempt to metaphorize a new kind of body of knowledge in old familiar idioms, still the idea that health is made is very deeply ingrained into this metaphor. If I'll have time, I'll go back to it later. Beyond scientific literacy, counselors appear deeply concerned with the moral aspects of their practice. They correlate prenatal diagnosis with eugenic motivations and are worried about the possible discriminatory implications of prenatal tests on people with disabilities. Some even have brochures featuring happy families with Down syndrome children and young adults to present to their clients. Their uneasiness with the moral implications of testing resonated throughout their accounts, unlike their American counterparts who, according to Rapp, were committed to the idea of non-directive counseling and transferred moral responsibility to the women and their partners. In the Japanese context, it is the genetic counselors themselves who feel that they are being pushed into moral pioneering rather than their clients, who tend to suspend fetal subjectivity. A genetic counselor that I met in Sendai told me, when I speak to clients, I always feel that my humaneness is being tested. I feel that many people undergo prenatal diagnosis without being aware of how heavy the choice that might await them is. I'm conflicted about how much I should say about a technological option which leads to such a heavy choice. Am I not infringing their right not to know? Her conflict echoes the key contradiction of a professional ethical commitment which aims to prevent Huan, namely, to communicate reproductive risk without exposing the pregnant mother to the risk posed by the risk information. Let me emphasize this point through a comparison of the formal definitions. This echoes in the formal definitions. The American Association of Genetic Counselors defines genetic counseling with an emphasis on understanding. I'm not going to read all of this, but genetic counseling is the process of helping people understand and adapt to medical, psychological, and so forth. And of course, it speaks about informed choices and other technologies to be managed. But here is the definition according to Professor Murotsky, who an OBGYN who heads the maternity department in a hospital in Sendai and is a member of the previously mentioned consortium, and he wrote the definition for the consortium. His definition emphasized the need of genetic counseling to solve clients' uneasiness, huang, okay? So here is his definition. I'll read it from the middle. Of course, he writes, genetic counseling includes offering professional knowledge and consultation and coordinating special testing. However, genetic counseling aims at supporting the client towards using this expert knowledge to make an independent choice and to resolve kaisho o mezasu, to resolve their uneasiness, their huang about heredity. And if the terminologies, and what about the women? That's the important question. If the terminologies of Rapp and Rothman are used to theorize the experiences of the 20 Japanese women that I talked to in last February, the tentativeness, the experience, seem far briefer than that of Israeli women, to take one example. This assumption, however, is a radical reduction of the anguish some of them experienced after being reassured that their fetus did not carry one of the trisomies. For example, Suzuki-san, a 42-year-old pregnant woman and mother of a 4-year-old, told me tearfully, when I was pregnant with my first child, from the very beginning, he moved, and when my stomach hurt, I said, "Gambarimashou, let's get through this together." This time, I waited for the results of the NIPT and did not say anything to the unborn baby. When the results came back negative, I said, "Forgive me," to the fetus. I apologize for not thinking about you, not talking to you properly. In my previous comparative study, I spoke with Israeli women who also suspended fetal subjectivity until they had received negative amnio results, which brought them great relief. While a few did start speaking to their fetuses, none apologized. Japanese genetic counselors seem acutely aware of such emotional strategies, and they are critical about them. Sasaki-san, an experienced genetic counselor, was keen to clarify her position about this. She said, "I want to tell you about something that is very important for me. It is about the mother-child relations. There are mothers among those who come for genetic counseling who do not or cannot pour love on their unborn baby. I think that is unacceptable, not to pour love on the baby in the belly. As a midwife, I'm sorry for mothers who cannot give love to their unborn children. Even if they choose, and this is very important, even if they choose termination, I think a woman should like to say goodbye to the fetus. I want the mother to take seriously the time she spent with her unborn baby. When I start the genetic counseling sessions, I make a point hearing from the mother about her feelings when she found out she was pregnant. Most women say, ureshikatta, I was happy. I proceed with the counseling wanting her to preserve and cherish that feeling. Significantly, bureaucratically, fetal death is acknowledged with a death certificate from 12 weeks of gestation. And as you will see, Sasaki's sentiments are echoed in hospital rituals that I discovered. כן, אני כבר מסיימת. On my first day at the Children's Hospital in Sendai, I noticed on the map of the hospital a space entitled prayer room, a space whose sole use I later discovered is to enact rituals upon the death of fetuses and babies. Whenever fetal death occurs, whether miscarriage after 12 weeks of gestation, a termination, or a stillbirth, the midwives dress the dead baby in a tiny cotton kimono they have prepared and put the baby in a special box filled with origami. These are the flowers, yuri flowers of origami, that they have folded for that purpose. The doctors and nurses and midwives then accompany the parents who carry the box, this is the box, down a side corridor to a special elevator which leads them to the prayer room. And as you can see, it's a round, quiet room with no religious symbols. They light incense, pray silently, and then the parents carrying the box are then escorted to the parking lot where a car awaits them and takes them home. This ritual, it was explained to me, acknowledges the efforts made by the mother in gestating the baby. These rituals are not simply a way of helping women separate from their dead babies, but rather acknowledging their relationship. The ritual described to me materializes the expectations underpinning Sasaki's concerns with suspended maternal bonding. Death is not a good enough reason for detachment. So, do these snapshots suggest a paradigm shift in the cultures of pregnancy and prenatal care in Japan? I don't think we're quite there yet. True, NIPT, a new diagnostic test considered highly reliable is now formally available, but it brings to the surface old concerns about selective reproduction with familiar connotations of eugenics. Regarding new modes of risk governance, practitioners of a local version of genetic counseling are evidently striving to promote a new scientific literacy. Their explanations are nevertheless featured in familiar environmental frameworks, in metaphors of nutrition, thus softening considerably the determinism with which genetic knowledge is rendered in Western countries. Are these practitioners communicating chromosomal and genetic knowledge more openly with patients? Not necessarily. Genetic counselors are in fact experiencing themselves as moral pioneers while trying to retain their commitment to a contradictory professional ethics of communicating risk while protecting pregnant mothers from the effects of exposure to risk information on their mental well-being. risk information, whether environmental or reproductive, is seen as a potential, yet very real and measurable, I didn't have time to talk about this, but it's measurable, health hazard for them. Are the experiences of pregnancy becoming tentative in Japan? Again, not necessarily. Women may try to suspend bonding while still confronting old maternal guilt. They are consistently expected to cultivate relations with their unborn children, whether dead or alive. Thank you so much.